Okay, so today we're going to examine the knee joint. First of all, to examine the knee joint, I like to examine the patient standing up in a neutral position. So as you are, that's good. So looking at the knees to see if there's any valgus or varus deformities, seeing if there's any femoral anteversion, which would cause an inversion of the patella, and also looking at the ankles to see if there's any pes planus or any loss of the heel arches. And then getting the patient to turn to the side. Good. Looking to see if there's any hyperextension of the knee joint and any obvious swelling within the posterior knee. And if you can turn to the back, again looking for any obvious valgus or varus deformities and any swellings or abnormalities within the posterior knee. Excellent. If you turn around for me. At this point, I'd like to walk the patient to assess the gait. So if I can ask you just to take a few steps over there for me and turn around. Good. And come back. Excellent. I then want to ask the patient to do heel walk, tiptoe walking. So if you can go on your tiptoes over to there, assessing active plantar flexion and stop. And can you do heel walking coming back? So active heel walking to assess active dorsiflexion of the ankle. Good. And if the patient can do both of these manoeuvres, then it suggests that the majority of their neurovascular functioning within their lower limbs is intact. Good. So if you take a seat for me on the bed. So one of the common cause of knee pain is actually due to radiation from radiculopathy pain from the lumbar spine. So first of all, I want to feel the lumbar spine, okay, to see if there's any pain or any radiculopathy pain down to the knee. Anything? Good. Then I want to assess the myotomes of the lower limb to see if this induces any knee pain. So we start off with L1, L2, which is hip flexion. So asking the patient to lift their leg off the bed against resistance. Good. And then L3, which is knee extension. So asking the patient to extend the knee against resistance. Good. L4, which is ankle dorsiflexion, so asking the patient to lift their ankle up against resistance. Good. L5 is big toe extension, so asking the patient to lift up. Good. S1 is ankle plantar flexion, so asking to push down into your hand. Good. And S2 is knee flexion, so asking the patient to pull in against resistance. Excellent. Good. At this point as well, I'd like to assess the dermatomes of the lower limb. So I always start with a neutral position, so such as the chest. So can you feel this? Good. So what I do then, ask the patient to close their eyes, assess left to right, asking whether or not there's any difference in the sensation. I'm only going to test one limb today for time purposes though today. So, sorry, you just push your hand down, slightly roll up your trouser leg. Your short legs, excellent. So if you close your eyes and let me know if it feels the same to your chest. So L1 is the top of the thigh. Yeah. L2 is the medial thigh. Good. L3 is the medial side to the patella. Yeah. L4 is just proximal to the medial malleolus. Good. L5 is the web space between the first and second toe. That? Okay. And S1 is the lateral edge of the foot. Good. Okay. And again, obviously assessing that left to right, and you'd also want to use pinprick sensation as well. Good. So then we ask the patient to lie down on the bed, so head in that way. Good. An important part of the knee examination is, in terms of assessing radiculopathy pain of the lumbar spine, is doing a straight leg raise. So here we passively lift the leg up, straight up as far as it will go, assessing for any pain within the lumbar region. No? Okay. If they did have pain, then we drop the leg to where the pain was reduced, and then we would passively dorsiflex the ankle. If this induced pain in the lower back, then this would suggest tension on the dura mater, suggesting a lesion within the spinal cord. Okay. Between 0 and 30 degrees, the lower limb nerves are not under tension, so it shouldn't cause any pain. between 30 and 70 degrees, there may be pain, and this would be associated with tension on the nerve roots of the sciatic nerve due to a herniated disc, for example. Anything above 70 degrees would be due to a joint problem, such as within the lumbar spine or sacral iliac joints. Good. Also, before going on to the knee joint, it's important to assess the hips to see if these cause any radiating pain down to the knee. I'm not going to examine that today, but you want to assess internal and external rotation. Good. Then going on to the knee itself, so taking another good look of the anterior aspect of the knee, seeing if there's any abnormalities. Good. I then want to feel down the quadriceps muscle, feeling for the bulk and tone of it, also comparing left to right. I then want to feel down the quadriceps tendon, where it inserts onto the patella, around the patella itself, good, down to the patella tendon, and where it inserts onto the tibial tuberosity. Good. Also want to palpate on the joint lines, so if we get the knee up into slightly flexed position, just to open up the joint lines, palpating over the lateral joint line, good, and the medial joint line. Pain over the joint lines can be indicative of a meniscal injury or degenerative changes such as arthritis. Good, just relax. Okay. I also want to assess for any effusions. Sometimes a large effusion is fairly obvious, and that would cause reduction of the natural guttering in the medial and lateral side of the patella. If it's more subtle, what you may want to do is just milk the suprapatellar pouch, good, and then do a patella tap. So this is where you ballot the patella down. Okay, good. If there is fluid there, then the ballotting will feel softer, where if there's no fluid there, it should be quite hard bone on bone. Okay. Also, what you can do is the patella sweep. So again, milking the suprapatellar pouch, doing a medial sweep up. That would cause swelling of the lateral board of the knee, and then lateral down. And again, that would cause swelling on the medial side. Okay, good. So then we want to assess the posterior knee as well. So it's important to feel posteriorly to make sure that there's no ruptured Baker's cyst in that area. Good. Then we want to move on to the range of motion, both actively and passively. Good. So we ask the patient just to bend their knee as far as they can towards their bum. Good. And back down again. Excellent. And what I want to do then is ask the patient just to push their knee down into the bed. Good. So you can see the range of extension there. Good. What I want to do then is passively flex the knee with my hand over the kneecap as well, feeling for any crepitus, and back down again. Good. And it's also assessing how much extension by lifting up the legs at the end, just to see how they hang. Okay. Good. So after assessing for range of motion, we then want to look at the individual ligaments within the knee joint itself. The first ligament we look for is the ACL, anterior cruciate ligament, and this can be done using a Lachman's test. So what I do is get the patient to relax their knee over mine on the bed, okay, and then with posterior force on the femur with my left hand, and then an upward force with my right hand on the tibia and fibula, just to see whether or not we can mobilize the ACL. If there is ACL damage there, then that movement anteriorly will not be as tight as what it should be. Normally it should be like a piece of rope where you pull it taut and it's very neat ending. Okay, good. Then we want to ask the patient to put their knees into flexion, so just 90 degrees flexion. And here we can assess for any posterior sagging to suggest a PCL injury. And again, it's good to look from the side to compare left to right. Good. And if you relax that one down for me, this one, good, and put this one back up. So then we want to assess the posterior cruciate ligament by doing a posterior draw test. Okay. So what we want to do is just grasp hold of the posterior end of the knee, and then just put a firm but slow force through the knee posteriorly to see whether or not there's any laxity at that point. Okay. Also, when the patient is in this position, you can do an anterior draw test. It gives to see the integrity of the ACL joint. Okay, but the Lachman's is by far the most sensitive test for the ACL. Good. We then want to have a look at the collateral ligaments of the knee joint. Okay, and by doing this, I get the patient just to scoot over towards the end of the bed a little bit. Good, and then put in the leg just down off the edge of the bed. Just relax your leg down. Good, just to give that little range of motion. And then for testing the medial collateral ligament, we want to stress the leg into a valgus deformity, so pushing out. And for a lateral collateral ligament, we want to put it into a varus deformity. Good. Okay. Excellent. The last part of the knee examination involves assessment of the menisci. Okay, so the most common test that we use is a McMurray's test. So here we take hold of the leg, so let it go. So take hold, flex your leg, and flexing the hip. Okay, fine. So to assess the medial meniscus, you want to put a varus force on and externally rotate the knee, seeing whether or not you can cause any friction or any trapping of the medial meniscus underneath the fibula and tibia, and extend that knee. Good. And you can do that in different angles and different degrees of flexion. Good. Okay. And then to assess the lateral collateral ligament, again similar thing, but what you want to do, the lateral meniscus, sorry, is to put a valgus force on, and again rotate and drop the knee down. Okay, so another test that we can do is the Apley's maneuver. So you get the patient to turn over onto their front. Good. Okay, and ask the patient to bring their leg up into 90 degrees of flexion at the knee, and again the attempting to internally and externally rotate and cause trapping of the menisci between the femur and the fibula. Okay, so with an anterior draw initially, we can internally rotate and externally rotate. Okay, and then by putting posterior pressure down onto there to try and squeeze the menisci together, causing internal rotation and external rotation. Good. Okay. Excellent. There are the manoeuvres that you can do, such as the Thessaly's test, which involves the patient standing up and again internally and externally rotating the menisci to see whether or not they can be trapped to cause any pain. A positive test of the menisci is any pain on movement in those regions, and that makes up the knee examination.